Welcome to SAEM. I am super excited to talk to you today about two potential solutions to fix the hospital issue of boarding in the emergency department. Your expectations are probably right over up here right now, right? I am joined by my colleagues over here, and we're going to talk about home hospital virtual observation unit. I'm the vice chair for clinical affairs in the Department of Emergency Medicine at Boston Medical Center, and before that, I was part of the team that helped set up home hospital program at Mass General Hospital. With me is Dr. Emily Hayden. She's the director of telehealth and the associate director for the virtual observation unit at Mass General Hospital. And the third person also presenting today is Dr. Kei Oichi. He is a researcher and a physician both in the emergency department at Brigham and Women's Hospital and also a physician with the home hospital program at Brigham Women's Hospital. But he's kind of a slacker. He got a Fulbright in Japan, and he's out doing great things, but unfortunately, he's not able to come today. But instead, we were able to pre-record, and we'll share that with you all about the home hospital segment. We don't have any financial disclosures, conflicts of interest to share with you today, nor do we have any in general. So raise of hands, whose emergency department looks like this at some point of time or day or just all the time? Yeah. So then I think we're among friends in the sense that we're all aligned in terms of trying to tackle the issue of crowding and boarding in the hospital, in the emergency department. And if you're, many of you are here interested in clinical operations or being part of a leadership team to tackle this. And there are many, many frameworks, right, in terms of how to think about clinical operations, processes. And just one framework that I wanted to share with you just to frame this conversation is the Asplin model, right, the Asplin framework. And there are really three segments in terms of the patient's journey or as a patient moves through the emergency department. There's the inputs, there's the throughputs, and then the outputs. And with the inputs, if you think about it as potential solutions that have come up are urgent care centers, right? Or just like the blunt tool of not accepting transfers, interfacility transfers, as it were. From the throughput side, it's sort of the meat and potatoes of what you do as an operations leader in terms of lean processing, Six Sigma, right? Plan, Do, Study, Act, PDSA cycles. And here it's just a constant movement of the needle to decrease turnaround times, decrease length of stay, which translates to getting that bed open sooner so that you can see the additional patient and tackle crowding that way. And then there's the output component to it, right, which is what we're really focusing on today. But with output, you think about the observation units that have blossomed. You think about models where we're temporary boarding patients on the hospital floors. But really, this is like what we're trying to present today is really this next step of evolution in how we're caring for patients outside the hospital. And why is this important? Well, soberingly is that this group here out of the University of Washington, St. Louis, they modeled all different systems, hospital level inputs and outputs. And they basically showed that if you don't address the inputs, if you don't address the outputs, then much of the throughput work can get hampered. And intuitively we understand this. The part of the results have been that as boarding rises, right, from 20th to 80th percentile, you start seeing effects on waiting rooms, length of stay, and then of course boarding begets boarding, right, as more patients are waiting and for admission. Excitingly, but also in the ashes of COVID, there was a regulatory change. And this regulatory change set up a fertile ground, right? Because at the end of the day, when we talk about who are the stakeholders who are going to be part of the solution, there's going to be the partnership with the hospital or system. And these regulatory changes basically set up a reimbursement model right? Pre all this, it was the small number of hospitals or systems that set up these programs really had to do it on their own. Maybe they got some physician telehealth reimbursement, but the regulatory changes that happened in March 2020, which really started it, right? This hospital without walls program during COVID, and that allowed you to temporarily take care of patients in hotels and in stadiums. But really in November of 2020, that's when this announcement of the acute hospital care at home came into play. And now hospitals were actually able to get potentially reimbursed on their side, which aligns then the incentives to potentially invest in these programs. There's two ways that you can, from a hospital perspective, apply. There's, if you had some experience, so a number of hospitals that prior did experiment, has an expedited review. But if you're totally new to this, then there is a detailed review that, again, you have to apply through CMS. Now, the interesting thing is that the hot topic is everyone's been focusing on inpatient, right? And there's a DRG associated with it. But the area of opportunity that Dr. Emily Hayden will share with you is that there's also a funding mechanism, a reimbursement for observation patients, right? Which is very within the realm of emergency medicine. And with this sets up the two programs that we're going to talk today, which is the home hospital program and this virtual observation unit. What we're not talking about today is the ET3, right? The 911 system where we talk about triage, treats, and transports to alternative cares. And instead, we're going to start off with Dr. Kei Oichi's home hospital and then lead into Dr. Emily Hayden's discussion related to the virtual observation unit, which is an extension, a component, where you tie community paramedicine, mobile integrated health with telehealth. At the very end of this talk, we're going to have an opportunity for just a Q&A. You know, many of you may already have your own nascent programs or mature programs in home hospital virtual observation unit, and there'll be an opportunity just to share potential best practices or issues that you yourself are coming across, and we can learn from each other at that point in time. So with that, spiritually, Dr. Kei Oichi.
Hi everyone, thank you for the opportunity to speak. My name is Kei Ouchi, and I'm an emergency...
Sorry.
Hi everyone, thank you for the opportunity to speak. My name is Kei Ouchi, and I'm an emergency physician and home hospital physician at Brigham and Women's. And today, I'm so excited to get to talk to you a little bit about our program to sort of spark discussions about what this means for emergency physicians. And I work on this service with Rob Boxer and David Levine, who are on this slide. They're my internal medicine partners.
Sorry, can people hear at all? Okay, perfect. Okay, good. Yeah.
So, I'm just going to jump right into what we offer. And the premise of bringing home hospital is that patients are going to get to access acute healthcare at home, and these three sort of large models are being proposed. Basically, on the left, we are trying to substitute the ED by kind of patient going from home to ED and then back home again to continue the inpatient level of service. The second model is where patients are admitted to the hospital already and they're on their way out in terms of their treatment. For example, continuing IV antibiotics for pneumonia or cellulitis. And those patients are stable and they can continue that therapy at home with the home hospital service. And what's coming, we think, in the future is this model on the right, where we're going to replace the whole ED and acute care hospital itself by pre-enrolling patients so that they will never have to come to the hospital to begin this service model. And this is what we give to our patients. The patient's home hospital care is surrounded by so. And in our home hospital model, we have this kind of configuration. We have a nurse or MIH paramedic who visit the patient twice daily, and they do what you think they would do. They administer medications, IV access, EKG, a bunch of in-person assessments. And then the physician would visit the patient at least once daily, either in person or virtually, to do medical decision-making as well as patient counseling. And we also have the capability of sending home health aides for patients who require more ADL help at home. And also, we can send social workers as well as home PT/OT. This is our home hospital model. And this is what we give to our patients. The patient's home hospital care is surrounded by our clinical team on the top and the right, as well as services like IV medications, remote vital sign monitoring, diagnostic testings like x-rays, ultrasound, echoes, and CTs even, and also 24-hour, 7 days a week, phone and video consultation with the physician or nurse. And this is just a list of diagnoses that we currently take care of. These include many things that you may be familiar with, like pneumonia or complicated UTI, and we also encompass things like end-of-life care. For example, I've had patients who had end-stage COPDs who was transitioned to home hospice after an acute exacerbation of COPD treatment. And these are sort of, fortunately or unfortunately, becoming more common nowadays because of aging population. And down below are the new diagnoses that we're looking into, and they are happening as we speak, and we're constantly trying to expand this list of service that we can provide adequately at home. This is our current catchment area on Google Maps. At the center, where the dot is where our hospital is in Boston area, and we encompass about 10-mile radius from there. And the physical distance to get to the patients by our clinical team is likely the largest barrier that we're facing in order to expand this service. And we are acting to try to figure out how to overcome this barrier by leveraging local MIH folks to train so that they can be our hands and eyes on the patients, even if the physical distance from the physician is far away. And as you probably have heard, in November 2020, CMS announced that they will start reimbursing home hospital service at the same level as inpatient services that we get reimbursed for inpatient. And they kind of came up with this waiver that includes a whole bunch of things, like the services that you must provide, like pharmacy and infusion services, and sort of like the minimum daily visits by physicians and nurses. This is pretty much all what we outlined because this approval process was mimicked by the publications and data that we in our hospital, as well as a bunch of other hospitals who have been doing home hospital for years, provided to CMS to make this hospital waiver approval program. And since that time in November 2020, the number of hospitals that are being approved to deliver home hospital service has really rapidly increased every month, as you can see on the graph on the left. And then this is the sort of like the map of where uptake has been, and darker blue represents higher proportions of uptake for these hospitals. And as you can see, it's spreading nationally like a wildfire. And since that time, until about October 2021, about a year from that time, CMS has tracked how many, sort of like what kind of patient populations that they are using these waivers for. And as you can see, most patients that these waivers have been used for reimbursement has been Medicare patients, as well as Medicaid patients and some dual eligible patients. And during this experience, CMS have sort of came up with other considerations and sort of fixing things as the concerns arise, like the experience of the institutions or patient safety issues, nursing oversight. These are all the concerns that have raised throughout this 1 year of experience, and CMS has actively sort of set different rules to try to address these concerns actively. So what I'm trying to show here is that this is an active process where things are still a moving target, and many rules are set based on the data that we produce to kind of set the standard of care for this service in the future. I hope this was somewhat of thought-provoking presentation, and I really thank you for your time. And I look forward to the discussions and discussing more about these topics. Thank you.
All right, and I'm fearing with that. This should be the one. All right, great. Hopefully this isn't too loud out there after they turned up the mic there for Dr. Luigi. So I'm Emily Hayden, as was introduced earlier. I've been at Mass General Emergency Department for 16 years, and I switched over from medical simulation to telehealth back in 2016. And then I'm here, though, today to speak about the virtual observation unit. So really excited about this. Before I start into this, how many people here have home hospital at their institution? So maybe like a quarter. How many people have a virtual observation unit? Okay, someone who's at our institution. All right, okay. We'll take that. He actually helped set it up, so props to Shy on there. So, all right, so we started a virtual observation unit January 3rd of this year, and it was a big day for us. In a way, it was sort of historical that we are in emergency medicine, another way that we can be caring for patients using our skill set, marrying mobile integrated health, which we'll talk about a little bit more in a moment, and then also telehealth. And so we started this on January 3rd. We had the previous year worked on a COVID virtual observation unit, which was specific for COVID patients for remote symptom monitoring and with mobile integrated health. And we also worked with a mobile response program, which is like an urgent, let's deflect patients from the ED from PCP and specialist referrals in our system. We're not gonna speak about those two other programs. We're gonna speak specifically about this one started this year. So what actually is this? If you think about it, we did on January 3rd, we expanded our ED observation unit and our ED bed capacity without having to knock down walls. All right, we were not having to go and ask the department, or actually the hospital, to ask for more room on the first floor for our ED or another room in the inpatient units for our observation unit. We now have beds and can care for patients at home under observation level care. So how do we do this? And that's what we're going to get into here. So what we're able to do, we have a couple of things. I mentioned there's the mobile integrated health, and that's what the first bullet point is on here. So this is specially trained community paramedics. So they've expanded scope of practice compared to paramedics who aren't community paramedics. They're able to go into the patient's home. So I hear from people that video-based telehealth is not going to work because I need vital signs. I have vital signs at triage. We have the paramedic that can be out there and get the vital signs for us that we can supposedly trust, right? So we have that one. We also have the paramedics be the hands-on, right? They can go ahead and palpate where the pain is. They can get a sense of even what's going on in the patient's home, more than what we're going to see in our sterile emergency department, right? Like we're going to be at their home seeing where they are. We have virtual support from our EM attendings, and actually EM attendings from across our system, because again, we can scale, right? Like it's virtual. We don't have to have just our emergency physicians from our emergency department. We have it from throughout our healthcare system. We're 24/7 for that. We enroll between 8 a.m. to 8 p.m. The team has the community paramedic, has the emergency medicine attending. We have a virtual observation nurse who's dedicated to this, not trying to do all these people are doing specifically this during that day. They're not trying to see other patients in person. And then also case manager, as well as our virtual observation coordinator, who's like the glue of the team, and they're amazing. What can we do? Well, we can do lots of things, right? This isn't just video-based telehealth. We have a paramedic there. They can do a 12-lead EKG and transmit it immediately to us. They can do point-of-care lab testing that they have on their truck there. They can also grab labs and bring them into our lab to run. We can give IV medications. So we have patients with volume overload receiving IV Bumex from us. We have patients who are receiving IV antibiotics. And then also we have contracted with another service to provide mobile imaging in the home. So we can have chest x-rays in the home. We can have other x-rays. We can have ultrasounds also, Doppler ultrasounds to look for blood clots and so on, DVTs and so on. And we have targeted clinical pathways, but we also recognize it's emergency medicine. Not everything we have is a clinical pathway. So we have a broad range of inclusion and exclusion criteria, but it could be multiple different patient conditions and patient presenting conditions that we're seeing. So we did have a pilot. We had a pilot of this back in September before we launched in January. During this time, we had 27 patients we enrolled, payer blind. We had a mix of clinical cases, and that this is what's informed our operational model that started in January. And then I have to give props to Cheyenne here, who's in the middle of the room here. This view of Epic, so those who are in Epic, or anybody who's in emergency medicine here, the electronic health records for emergency medicine are insanely hard to bring in virtual care. And we're not talking about virtual beds where like they're in our hallways virtual beds, but like virtual care from patients outside of our physical ED. We got this done, and so thank you, Cheyenne, to his team and working with Epic to have on here. So this is our track board, and we have, it may be hard to see from out there, but we have on here, we have ED patients, obs expects, waiting, expected, virtual observation unit. Okay, so these are patients still that we're caring for. They just happen to be not in our fast track area or up in our 12th floor observation unit, but at their home. So we have inclusion criteria. They have to be over 18. They have to have secure housing. We cannot go out to shelters for this. We have been able to go to hotels if people are in town visiting and they're in a hotel, and we can go to those, but otherwise we have to, we can't take them. They have to be enrolled during the daytime. We'd like to be enrolled during the night. We just don't have the full team available during the 24/7 period. We only have the physician. So the overnight is for the physician to be ready for patient escalations or questions. And then they have to be referred from our emergency department or our observation unit. So currently we're not pulling these patients from home. We would like to at one point, but we are not doing that. And we also would like to pull from others or have other virtual observation units for our EDs in our system too. And then it has to be appropriate, and we'll get to the appropriate, not the appropriate, but the list of conditions that we suggest are appropriate for this. So the exclusion criteria, sorry this got a little bit off, it looks like on the formatting here. So the exclusion criteria, when we're looking at this, there's a lot of them. And it's true, like we're trying to do what we do in emergency department with all of these resources and try to take it at home. So there are gonna be some issues with that. And also home-based care, even if we had everything available, there's things there that we just have to be aware of. We like to think of things as modifiable and non-modifiable of what we can do to try to increase the proportion of patients. So non-modifiable is that they live outside of our beltway. So there's a picture recently of sort of the area that we cover geographically. If a patient's in New Hampshire, not gonna happen. I don't have my license for New Hampshire. We can't do telehealth in New Hampshire from Massachusetts. So those are non-modifiable. But some of the modifiable ones would be that we're working with things such as PT, OT, and case management for placement. Is there a way for us to have them provide some telehealth, video-based telehealth, or maybe have PT, home PT come in to evaluate these patients in an area that we actually are probably trying to see, are they safe for home? Well, why do it in our emergency department? Let's do it in their homes. So we're working on different avenues and working with different specialty consultants to see if they can, rather than wait and have that attending neurologist come and see them in the morning, in the ED, can we actually have them do it by video at home? Of course, high-risk features, if they are looking septic, we're not gonna take those patients. If they require blood transfusion, our home hospital team does do home blood transfusions, so it's not out of the question. We just have decided not to do that yet. And so on. So we have several things, working on some of them, some we're not gonna be able to change. And this is one of the reasons or one of the pieces of why I wanted to know how many people in this room had home hospital or institution, because this exclusion criteria, if you don't have a home hospital program in your institution yet, it makes this exclusion criteria even more. Like we're already working on some of the infrastructure that was already in place. And so once things are scaling up more and more, we probably will have less inclusion criteria. One other thing to point out on here is that some of the exclusion criteria for this is different than what we'd be doing in our emergency department, in that we want to make sure our paramedics are safe. Okay, so when the paramedics go out there, we want to make sure they're not going to a place that there's a risk of intimate partner violence, that there's not active substance use disorders, that there's not active psychiatric concerns that would make it unsafe potentially for the paramedics. So. All right, so the clinical conditions. So these are the ones that we sort of market. I don't want to say market, it's a bad word, but we put forth to our clinicians in the ED to say these are ones that we think would be great for being able to be seen over virtual obs units. So COVID that doesn't require supplemental oxygen, great. Pyelonephritis, gastroenteritis, diverticulitis. And so some of these ones that I try to tell my colleagues is that if this is a patient who you're like, yeah, the CT shows diverticulitis, not perforated, no abscess, but we just want to make sure they can tolerate food. They're still sort of tolerating food. Well, we're going to wait a few hours. Let's get them home, okay? And I realized a key point, I actually didn't tell you what happens when they go home. So let's say a patient is on one of these conditions. What happens is that the ED team, if they feel like a patient is appropriate for virtual obs, they will place an order in Epic, which will then page our virtual observation unit team. The observation unit team, the nurse, the case manager, the clinician, the attending physician, the paramedic will all look at the chart and determine is this appropriate or not. If it's determined to be appropriate, we have our virtual unit coordinator go out to consent the patient, right? Because consent is one to say that you'll be billed for this, right? Like to make sure that patients understand that. During telehealth, people were sort of surprised that they did a video visit and they're like, wait, why am I getting billed for this? I didn't come in to see you. So we have to make sure they understand that. We also have to make sure they understand that or agree to have a paramedic come into their house. Once they consent, we give them a backpack with tech in it, our tech bag. Tech bag has an iPad in it for the use during the program, as well as a hotspot in case someone doesn't have good broadband or Wi-Fi. They have blood pressure, temperature, pulse oximetry equipment, pulse ox, in the bag, and then they will go home. They'll go home with the bag, and what will happen is that during their observation stay, our virtual observation nurse will be calling at the same time as if they were going into the patient's room for vital signs. They would ask the patient for their vital signs and walk the patient through obtaining their own vital signs. They would go ahead and document medications on the medication administration record of what the patient had taken at home there and check in with the patient. They'd feed that information to the clinical teams on MS Teams chat. And then once or twice a day, we'll have the paramedics go out to see the patient, do a video visit with one of our attending physicians, and then determine what's the next step. Will it be another visit the next day? Will the patient be discharged? Do they now require inpatient level, and do we now work with our home hospital team to say, can you now admit this patient? So the patient could all of a sudden go from our ED to our virtual observation unit to our home hospital inpatient without having to come back into the ED, and so they can stay at their home and continue recovering there. They also have the ability to come back to our ED if they need a higher level of care and or be admitted direct to our inpatient service in person. Key thing I didn't tell you before, so sorry. I want to make sure you understood what happened with them. So I'm going to make sure that we open this up to questions. So if you have any questions, my thing's in the SAEM app. This is my email too. But I wanted to make sure that if there's questions or comments, anything, we have the mic here that we're going to make sure is not muted there. So questions? Okay, great, yeah.
Howdy, Ian Brown, Stanford. I have a few questions, but let me start with an operational one. From the time the order is placed until the time that the patient leaves your physical building, how long does it take in order to set this whole thing up? And as a second part to that question, do you have a sense for, of the people that you do this, how many would be admitted versus how many would be outpatient? Because not everybody who meets admission criteria would be admitted. There are COVIDs without oxygen. Yes, they could come in, but how many of these come in versus home? Right.
So to answer your second question, we haven't pulled the data yet. We can sort of have a general gist of how many patients. We have case managers that are leveling patients, make sure they're not observation level or inpatient level, but we also know that we are at such a capacity crunch right now in our ED, in our hospital, that the more that we can try to offset, even if it's for 6 hours or 8 hours, that's space in our department. So some of these patients may not have leveled even for observation. I'm sure for those of us who actually have observation units in your hospital, there's also probably patients that wouldn't level for observation, but yet we send them to the observation unit because we need to get them somewhere, right? Like they're not ready to go for a myriad of reasons. So it's data that we haven't pulled yet. It's more just ad hoc. And the first question you had was how long it takes once they consent. So if some of these patients are really ready to get home, so once that tech bag is in their hand, they're like out the door. So they can go quite quickly. Then there are patients who may need a chair car or a transportation home, and we have a big crisis with, I think, which is happening across the nation, but the crisis with paramedics and transport by EMS, and so they may be sitting 6 hours in our ED, unfortunately, even though everything's ready for them to be home, and we're all ready for them to be home, but we're waiting for that transport.
But your process from when the doctor wants to do it until the time that you get the consult,
Yeah.
your worker sees them, your team sees them, how long does it take, from the time the order is placed or from the time the doctor thinks they're ready until they're actually ready?
It could be anywhere from, with the consent and everything, probably 15 to 30 minutes on ones that were like, yeah, this like totally does, to some that may take an hour or two, just because it may be like, hey, can we wait and see what that second trope is to make sure we feel comfortable before going home? But most of the time we could probably get it pretty, once that page goes through, it's probably sometimes as quick as 5 or 10 minutes, because we may have already been looking at the board saying, like, nudging that people like, hey, you know what, that one might be a good one for us to virtual obs. So it's a little bit of a, it can go, but it could be quick. And especially with our goal, we're trying to get these patients out of there, so there's definite like motivation to try to get them out quickly. So there's someone else back here with a mic. Great.
Hi.
Yeah, we can hear you.
Sorry, cool.
Yeah.
Andrew Underhill, I'm an emergency physician from Melbourne, Australia. I'm really interested in this because we're kind of in the nascent stage of looking at this as well, and we, for years, have had hospital in the home as a system within our state. In terms of your scalability, what's your patient number that you've kind of got under a virtual bed card?
Great question. So currently we have that currently are operating under 5 patients at one time. So if we have one patient that's discharged in the morning, we still have ability for 5. So we have 5 there. The goal is to be soon trying to get up to 10 patients a day. So again, that's expanding. And actually, I'm going to have to look at you, Brian. How many beds do we have in our observation unit, since you used to oversee, what was our MGH?
31.
So 31. And we're expanding up to, we're going to have 10 beds. So we went from effectively 31 beds up to 41 beds with this one. So,
Great.
So that's what we're looking at scaling, at least for now, with the team size we have. When we go up to 10, we're going to feel like we're going to be pretty strained on the team. So that's at the point where we may need to start saying, do we need to have double physician, double paramedic, and so on.
Yep.
So
And just another operations question. Then in terms of length of stay, what kind of, do you have parameters or saying, look, is it 24 hours you're going to keep these patients under your card, and transitioning that back into primary care or onto hospital in the home? Because I think, novelly anyway, for emergency physicians to keep, under our care for longer than 24 hours becomes probably something that we are less comfortable with, I guess, and it's also that clinical governance of the handover to a community-based provider or how that works for you. So what's your thoughts on that?
yeah. Yeah, so we have, we do 24 to 48 hours. So we mimic what we do in our ED observation unit, which is, there's the different ways. Should be under 24 hours, 85% chance they're going to be under 24 hours. That's when we're going to try to admit. We have patients that are in observation unit, in-person observation unit, that's like 48, and then some of these that are waiting for placement. Again, problems with all the stuff going on in the environment where post-acute care, it's so hard to get patients in rehab. So we have patients that are there for several days now. But the goal is, we try to mirror what's our our in-person ED observation unit. So we're saying that basically, if we're now hitting 48 hours, if we're hitting that second day with checking in on them with our nurses and our mobile integrated health visits, unless we think like, tomorrow, if they just have one more thing tomorrow and it's our third day, let's just go ahead and do that, we'll do that. But otherwise, we're like, okay, it's time now to think what's that next step. And so yes, the option could be discharge in the PCP. Like if we think they're fine, but if they still need someone to be monitoring them, then that's when we reach out to the home hospital colleagues and work on trying to have them basically take over the care from there. Readmission, I had a... sorry, I didn't hear the last part.
So is it staying similar to your admission, like ED observation in like in Australia, let's say, we'll sit about 50% failure, so 85% go home, 50 fail and get the.
Yeah, we don't like failure though, but yeah, no, it's about there. I don't have the numbers right now. This is a graph to show you how many actually remained at home. So if you look here, we had at one point we're hitting down to 65% of the patients were remaining at home, and the blue line is the virtual observation unit. But most of the time we're 70% above, so we're hitting about like the 15 to 25%. And I think that This is still a very new paradigm, even though we had something similar of this past year available to our emergency department patients. It's still new. So to be able to, I'm looking forward to when things get to be a little more steady state, where people are much more comfortable and understand this much better because it is so new. To say that's what we think is probably, I think there's a lot of sort of mixed things in this implementation period on this one. So yeah, could we maybe be at the 15% are the ones that have to be either admitted to home hospital. And I should say on this graph too, this would also include patients that did need to go into inpatient level, but they never came back into the hospital. So there may be a couple of these patients on this graph that were admitted to home hospital, trying to, that home-to-home time of 0, trying to really get them home and stay home. Yeah? Oh, microphone somewhere.
I have it back here.
Oh, there's Dr. Wang, yes.
Dr. Lulu Wang from Georgetown. Thank you both. 2 questions. So we implemented a COVID remote patient monitoring program about a year and a half ago. A large number of the difficulties we encountered came from one of 2 things. One, patients were sent home with a kit. In our case, it was just a pulse ox, but we didn't have someone on site who could explain to the patient how to use it, and so we had a very significant drop-off as soon as they left the hospital. And 2, so the first question here is, did you have someone on site to help with enrollment? Because even virtual, a nurse trying to explain over the phone or even over the video how to use these devices seems to be very difficult for some patients. And then 2, was there any active remote monitoring of vitals, or was it generally the 2 times a day when we called in and had the patient self-report?
We had our virtual observation unit coordinator that would show them how to turn on and off how to use the iPad, as well as how to use the pulse oximeter if patients said that they need some help on it. So if we were able to expand the team more, will we have some tech guru that'd be able to go out and help them out with it, sort of like the within ED Geek Squad of Best Buy type thing? That'd be ideal. We didn't, but we did have our virtual coordinators helping with some of that. And then the second question is that we didn't have any of the smart devices that would be sending information to us. It was when the nurse would be checking, but we will be probably soon have the ability to do telemetry. So back to the idea of the modifiable, non-modifiable. So modifiable is to be able to have telemetry patches that they can wear so we can actually obtain those and have those real-time streaming to us. That is coming down the pike soon. So, but right now, yes, it's calling and checking in. Yes.
Yeah, hi.
Yeah.
My name is Christian Klauke. I'm an assistant professor at UMass Medical Center. Thank you for the great talk. Just from an operational standpoint, of the patients that you discharged in this virtual obs unit, what percentage did the insurance say we're not going to cover this after the fact? I know you said that you had them sign a waiver. Mm-hmm. I guess they would cover it. And just, do you have a sense of what the daily cost would be to the patient if it was out of pocket? So I guess it's kind of 2 questions. Obviously in Australia, I don't have this operational problem that we have here, right. But it's a great system if no one's going to pay for it. For certain, the cystitis example you gave, or the acute gout flare I think you mentioned. I don't know if insurance would, certain commercial payers would pay for that. I don't know.
It's a great question and a great point. So we decided, when I say we, it was our system, including billing and compliance, had decided that we are going to bill observation level care to Medicare patients only, because that was part of the waivers that came out during the pandemic. So for our patients, if they're Medicare, we're billing Medicare, and we've received observation level care. We've received payment from that. For those patients that are on Medicare, we were billing only for the telehealth video visit, and we were using office-based codes, so not the emergency medicine evaluation and management codes. We were using office-based codes, which is what during the pandemic, most of the places, even though emergency medicine ones were available to bill for via telehealth, most programs were using the office-based ones. So. So the paramedics are essentially a vendor, and so per visit there is an amount of funds that flow to them per visit, and that's something that's contracted with. So we have 2 EMS companies we work with for this, and they both have contracts. One is within our healthcare system, it's our ambulance service, and another one, so they don't bill for this, and that's that piece that Brian had said earlier, the ET3 model, where they have that they're able to, with 911 activation, bill and be reimbursed for non-transport visits. This one, they're not receiving anything from payers. It's coming from our pool of money to them. Does that make sense for the EMS?
You're still trying to test the models. You're subsidizing the medic service currently as future.
Yeah, yeah. I mean, it's no secret that there's a huge resources from the hospital and funds from the hospital to do this, that this wasn't something that day one that we were covering our operational costs. We're not.
You actually might be, because the person now not in that bed, someone else is
So it's that value proposition.
transplant patient, so actually it's probably an opportunity cost for us.
Right, so it's that piece where it's the other stream, up, down, whatever you want to say, affects, rather than saying we're actually getting exactly the amount of money that we actually had to pay for it.
Hi, this is Andrew Wong from UC Davis. Just a question, is virtually all the patients who failed OBS go into the virtual hospital pathway? Were there any patients who actually had to physically come back to the hospital, and what logistical issues did you run into those?
So during our pilot, we had one patient. So the thing is too is that while patients may have a call button at home, sometimes their call button is calling 911 because they get scared. So we have had patients who are in our observation status at home, and they all of a sudden are scared, or just like they syncopized a couple times at home, and the family's like, so they sometimes arrive in unannounced to us. So it's like them walking up to the nurse's station at OBS, but it's like they come all the way in, which throws a lot of things into a tizzy. For those who can't go into home hospital, logistically, sometimes home hospital is full. They're at capacity too. So while we try to do that, sometimes the patient has to come into, and the idea of trying to get into a direct admit, that's also sometimes hard. So most of the time, if those patients cannot get into home hospital, they'll come into our ED and then unfortunately, potentially wait for a while for an inpatient bed. And sometimes they come in and they might need something where they need like maybe a PECT. It's a COVID patient that now is maybe a little bit worse, little different symptoms, still doesn't need oxygen, but might need that PECT. We can't do that at home, right? So they'll come back, get that, and then we can take it back to OBS. So.
Dave Whitehead from Hammer. Let me just can I speak up, or?
It's recorded, Dr. Whitehead, so we're going to have you do this by the microphone.
Dave Whitehead from Hammer. I've had the pleasure to work with Emily on shift and see this evolve. It's incredible. I'm curious if you'd be willing to go into the details of what is driving that failure rate, what tend to be the big buckets of failure mode, and to your point of modifiable versus non-modifiable, any early learnings from that you're thinking about?
Yeah, I mean, I think in terms of the rate of those that need to be readmitted and that, and I keep hearing failure rate, and it's interesting because for me, it's just that the patient's dynamic, and we have the same thing in our observation unit. And so, it's an admission rate, like how much admission rate. And I think for these that sometimes, I don't know if we've really found a pattern quite yet. Each time it's sort of individual specific. It's now all of a sudden the person's now in rapid AFib. And we don't have the actual paramedic at that time available to go at their home to go ahead. They had to come in, right? So, and then there's another one that they're just not getting better. We thought that they were going to get better. They still can't tolerate POs. So, so that's some of them. I don't have a watch on. I think we're having the
Yeah, well, I just want to say, with this is operationally it brings up a total new challenge, right? And I think the medicine is one component to it, but the people who are going to do really well in this is like the ones who solve the logistics issues, right? The UPSs, the FedExes, because you lose efficiency as soon as you start spreading all these patients out throughout a particular area, right? As opposed to room after room after room. So I just want to say thank you all for being an engaged audience, and wish you best of luck, and thank you. Enjoy the rest of the